Hi, I'm Mr. Cass, Urology consultant. So this is a demonstration of a TURBT operation, which is a resection of bladder tumor. So we're going to shortly resect the bladder tumors. We do inspect the rest of the bladder as well. As you can see, there are lots of trabeculation in the bladder. The bladder looks a bit muscular. So this is what we call trabeculation, which is muscle fibers that are prominent. And this is a sign of bladder outlet obstruction due to prostatic enlargement. So we start resecting the tumor with a loop. This is a bipolar resection. So we use electrical current to resect the tumor piece by piece, as you can see here. This is called the fractionated resection of the tumor. We did have some instrument problems, unfortunately, and so we replaced the instruments and we continued the resection here. So one of the main risks of resecting tumors on the left lateral wall of the bladder or the right lateral wall is what we call the obturator reflex, which is a stimulation of the obturator nerves. So we ask the anesthetist to fully relax the patient. So we continue here to resect the tumor piecemeal, uh, fraction by fraction, using the electrical loop. The aim is to reach the floor of the tumor and sample some of the bladder muscles, which is the deeper layer underneath the lining of the bladder. Now we will focus on resecting the second tumor. It is bleeding a bit, which is not uncommon. Now there's different ways of resecting bladder tumors. You can do a reverse resection, as in demonstrated here. If the tumor appears to be on a stalk, then you can do a reverse resection by targeting the stalk, and then the whole tumor can come off as one piece. And the advantage of this technique is to prevent charring of the tumor, but you need to have some experience in doing that so that you don't perforate the bladder muscle. Also, the advantage of it is very controlled, as instead of applying a continuous current, we do a one-off current application. So most of the tumor has been resected here, and we can see some muscle fibers as well at the floor of the tumor. Same thing here. We'll try and reverse resect this area here. Okay, so that's satisfactory resection. Most of the tumor has been removed. We do check the ureteric orifice opening, which is the opening just below the tumor that you've seen there, a glimpse of a minute ago. We try and remove any visible tumor, and this is the floor of the tumor, and that's the ureteric orifice there. And just removing all the edges. This is all unstable looking mucosa. That's the ureteric orifice there. So now we'll focus on the right side tumors. We'll try and do some reverse resection initially. And you see it's just intermittent resection rather than applying a continuous current. We do intermittent current, which has less risk of causing perforation of the bladder or damage because you're not applying the current for a long time. But then here I'm just doing the normal resection way because the area is quite large, and it's more feasible to resect it in the normal traditional way, which is continuous current resection rather than reverse resection and intermittent current. Again, good resection here down to muscle. We are very wary of the obturator reflex, which I mentioned earlier, where the large obturator nerves runs close to this area, and the anesthetist kindly has paralyzed the patient to reduce this obturator reflex. You can see air bubbles coming on and off sometimes in the screen, and we just twist the camera to get the air bubbles out of the way. This is the downside of bipolar resection. It creates lots of air bubbles, which can be removed by twisting the camera up. Here as well, we resect superficial resection. We don't want to cause any perforation while we resect the superficial areas. Some people just fulgurate these areas, i.e. destroy them with diathermy rather than resecting them, which is also another option. We see here very good and deep resection down to muscle on both sides. This is the opening of the left kidney pipe. This is a very nice resection area down to muscle. Same on the, now this is diathermy. We use something called the rolly ball, which is a coagulation device. Excuse me. We coagulate the area, and you can see if there is an abnormal or unstable mucosa, it becomes very white and fluffy when you coagulate it. And that's an indication that there might be some cancer cells in this mucosa, whereas the normal mucosa usually doesn't give you that fluffiness and whiteness when you coagulate it. So the purpose of this is to stop any bleeders. So we try and coagulate the floor of the tumor, which is usually where the large blood vessels are. You see it's a very big vein here, which is being coagulated. We're trying to avoid coagulating the urotheric orifice, which is down at 6 o'clock. You can't see it very clearly here, but we've demonstrated it before, because coagulating the urotheric orifice can cause obstruction to the kidney, which can be catastrophic for the patient, as it might cause permanent damage to the kidney. So we continue coagulating the area until we're happy that there is no abnormal area that needs destroying and that there is no bleeding blood vessels. We'll do the same on the other side. We try and focus on the edges of the tumor. That's where most of the bleeding happens. So coagulate the edges. You see there's an abnormal area here, and you see the fluffy white effect of coagulating the area. There's still a bit of fat in here. It's still a glistening fat here, and that's a sign of a deep resection. You've gone beyond the muscle layer, which is fine, which is a sign of a good resection. But as long as you don't perforate the bladder and cause a big hole, this is absolutely fine. So again, coagulating the, again, looking at the fat area, just making sure that there's no perforation. This is probably a tiny perforation. It shouldn't be of any consequence, especially in this location. Perforation of the dome of the bladder are more serious because they are connected in the intraperitoneal space, which is inside the tummy. So we're inspecting the bladder here to make sure there's no other lesions. I'm happy, nothing else remained, and the tumor has been resected completely. We withdraw the scope, and that's the urethra, that's the sphincter muscle. He did have a bit of stricture in the bulbar urethra, as you can see here, narrow area, but it's not narrow enough to warrant any treatment at this stage, so we did not intervene. So this is the same pictures, CT scan and MRI scan pictures for the same patient. As you can see here on the CT scan, the tumor is on the left lateral wall of the bladder, which we had just demonstrated and resected. It looks superficial tumor. The contour of the bladder is maintained. There is a smaller tumor here, further lateral to the original big tumor. As you can remember, there were two tumors. One was bigger than the other. This is animated pictures. You see that's the bigger one. And then if you go more lateral, there's a smaller one. We resected both successfully. This is a MRI picture of the same tumor. This patient had an MRI for another reason, and you can see here a quite superficial tumor, and it doesn't look like it's invading the muscle of the bladder, which is the layer just outside the tumor, the darker layer. As you can see in the pictures here, the tumor looks superficial to that layer. This is animated pictures of the MRI. Thank you.